Good afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on alcohol risk and policy, inequities in alcohol use and harm. This is part one of a five-part series. My name is Dr. Erin Hoban. I am a senior scientist at Public Health Ontario, and I have the pleasure of moderating today's session. So to start today's session, we would like to acknowledge the land we're meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 of the Mississaugas of the Credit. I will mention a few housekeeping items. The first is that the chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. If at any point during this session you experience any technical issues, please email capacitybuilding@oahpp.ca. And I would like to state that as the moderator of this session, I have no conflicts of interest. It is now my pleasure to introduce the speakers for today's presentation, Dr. Brendan Smith and Dr. Naomi Schwartz. Dr. Brendan Smith is a scientist at Public Health Ontario in the Department of Health Promotion, Chronic Disease and Injury Prevention, and an assistant professor in the Division of Epidemiology at the Dalla Lana School of Public Health at the University of Toronto. Dr. Smith's primary research interests focus on the application of epidemiological methods to estimate the health equity impacts of population health interventions. Most recently, his work has focused on estimating the effectiveness of population-level alcohol policies to reduce social inequities in alcohol use and harm. Dr. Naomi Schwartz is an epidemiologist lead at Public Health Ontario in the Department of Health Promotion, Chronic Disease and Injury Prevention. She holds an MPH in epidemiology from the Dalla Lana School of Public Health and a PhD in geography from the University of Toronto. Naomi's current research focuses on the social determinants of health and alcohol and cannabis use and harms. So I'd now like to pass it over to Dr. Smith to begin his presentation.
Great, thank you very much, Erin. So I'm really excited to be here presenting some new research on inequities in alcohol use and harm from our lab that I co-direct with Dr. Hoban. I'm presenting today with Dr. Naomi Schwartz, who will provide an example of research evaluating the health and equity impacts of an alcohol policy from the Ontario context around the sale of alcohol in grocery stores. So as Dr. Hoban mentioned, our presentation is part of a larger PHO rounds series on alcohol and alcohol risk and policy. So in addition to today's session, we have 4 more sessions that are planned throughout the winter and the spring, and we hope that you will join us and participate in the discussion on this important topic. The learning objectives for our presentation are listed here today. So first, we want to discuss the differential exposure and vulnerability and how these relate to some of the emerging research on social inequities in alcohol use and harms in Canada. And finally, we want to understand the potential impact of population-level policies for reducing social inequities in alcohol harm. So before we start, I want to now acknowledge my collaborators and co-authors in this work, including Drs. Hoban and Schwartz, Alessandra Andriacchi, who's a PhD student in the Division of Epidemiology at the Dalla Lana School of Public Health at the University of Toronto, Dr. Claire Benny, who's a postdoctoral fellow working on our research team, and also Samantha Forbes, who's a current member, and Christine Warren, who are both who's a former member of our research team. So I'll start today with the high burden of alcohol use, and that alcohol is a leading cause of death and disability in Canada and internationally that causes over 200 negative chronic and acute health harms. We know from estimates from the Canadian Substance Use Cost and Harm Project that alcohol has a high cost burden, higher than any other substance, including tobacco. In Ontario in 2020, this resulted in a cost of $7.1 billion due to lost productivity, healthcare, criminal justice, and other costs, leaving Ontario with a total annual alcohol deficit of close to $2 billion. Alcohol is also the most commonly consumed psychoactive substance in Canada, with roughly 80% of Canadians reporting that they're current alcohol users in the past year, and 1/5 or 20% reporting heavy episodic drinking in at least monthly in the past year. But we know that this high burden from alcohol is also disproportionately experienced across individuals with lower socioeconomic position. Socioeconomic position refers to the social and economic factors that influence what position individuals or groups hold within the structure of a society. Risks of alcohol-attributable mortality through meta-analyses and systematic reviews were found to be 3.8 to 5.2-fold higher in individuals with low compared to high socioeconomic position. There's also literature that suggests that the impact is greater in men than in women, although this is dependent on the indicator of socioeconomic status or position, mainly around around occupation. So here's some data I pulled from the PHO snapshot on 100% alcohol attributable hospitalization by material resource deprivation in quintile, so measured at the area level. And what we see here is with each quintile of increasing deprivation, we see higher age standardized rates of alcohol attributable hospitalization. And this is a pattern that the inverse gradient pattern that's very common when we study the impact of social factors on health outcomes. To better understand the potential mechanisms, we can use conceptual framework and like this one, which was proposed by Whitehead and et al. On the health impacts of social position. One line of inquiry in this framework considers an individual's social position and how that position influences their exposure to exposure to important health risks. We can think about one possible pathway as leading through differential exposure, which includes different social positions may carry different probabilities of being exposed to specific health hazards. We also might consider that the size of the effect of a certain risk factor or condition will often be dependent on the presence of a third or contributing factor. And in our example today, this could be considered socioeconomic position. But the societal perspective focuses on how the prevailing social context interacts with and influences this pathway from social position to ill health. Social context is taken to mean the interwoven elements of political, cultural, social, and economic environment which characterize society. And we can think about three potential interactions here and potentially even more that are denoted by A, B, and C. So first A, the arrow, policy may influence the social position individuals occupy within a society. We may also consider that policies may influence exposure to health hazards faced by people in different social positions. So here we might think about things like drinking environment, culture, alcohol quality, or even increased alcohol availability in low-income neighborhoods. A third potential policy target where it may influence the effect of being exposed to the hazardous factor in general. So once exposed to alcohol, are there certain things or policies we can do to reduce the likelihood of experiencing an alcohol attributable harm? So much of the research to date has focused on the potential differential exposure, and this makes a lot of sense. If there's a group of individuals who, on average, consume more alcohol, we might assume on a population level that they would experience more alcohol-related harms. And this is very much the case for men who consume more alcohol on average and experience larger percentage of alcohol harm compared to women. However, evidence from systematic review and meta-analyses found that on average, heavy drinking only explained up to 30% of the relationship between socioeconomic position and alcohol attributable mortality, and volume, including the quantity or frequency of alcohol use, explained only up to 15% of the relationship. So this leaves a lot unexplored in the potential relationship explaining this finding. This finding has been termed the alcohol harm paradox, where individuals with low compared to high socioeconomic position experience disproportionately greater alcohol attributable harm, despite consuming similar or less alcohol. There are a number of potential mechanisms that have been explored in the literature and summarized in this review that I've referenced into several categories of potential explanations. So, for example, individual or lifestyle factors may be different across socioeconomic position, including smoking, overweight, or obesity. We may also expect difference in contextual factors, including social support or drinking context, or in cumulative disadvantage experienced across the life course, and also things like differential access to healthcare. We can also think about more upstream or structural factors, things like employment status or opportunity. And then there's even a line of inquiry that looks into this relationship potentially being an artifact caused by different measurement error or underreporting that's common in alcohol epidemiology. This leads us to the differential vulnerability to alcohol pathway that was in the conceptual framework. This is an understudied mechanism on the potential explanation of social inequities and alcohol harms. Under this hypothesis, we would assume that at a similar or at the same level of alcohol use, an individual with lower socioeconomic position may experience more harm than an individual with higher socioeconomic position. There's emerging evidence to support this, looking at the joint effect between low socioeconomic position and higher alcohol use. And this joint effect is what we talk about in epidemiology being an interaction, and particularly valuable to look at this on the additive scale. And this finding or gap in the literature led us to conduct two different research studies. So the first is on the joint effect of education and alcohol use on 100% alcohol attributable hospitalization or death in Canada, which was published this month in Epidemiology. And the second is the joint effect of socioeconomic position and alcohol use on 100% alcohol attributable emergency department visits, which is currently undergoing peer review. The objective of these studies were to estimate the sex and gender specific joint effect of education and alcohol use, measured both in terms of heavy drinking and volume of alcohol use on each of these two outcomes. So each of the two studies is represented here as 1 and 2. We conducted this research using data from the Canadian Community Health Survey linked to health administrative data sets. This data was performed by Statistics Canada and available for researchers. And what it entails is pooling a number of CCHS or Canadian Community Health surveys to create a study population and then following them over time for health outcomes, including hospitalization through discharge abstract database in the Ontario Mental Health Reporting System, ED visits or emergency department visits to the National Ambulatory Care Reporting System or NACRS, and death through the Canadian Vital Statistics database. This novel data linkage includes valuable information for studying the alcohol harm paradox, including individual level measures of socioeconomic position, alcohol use, and up to 15 years of follow-up for alcohol attributable harm. So here I've noted the study populations for each of the studies. So alcohol attributable hospitalization in blue. And for this study, we use data from the 2000 to 2008 CCHS, and then purple, the alcohol attributable ED visits paper, starting in 2003. And the reason for this difference is this is when ED visits were first linked into the cohort. We also have some notable exclusions, including provinces where we had missing follow-up and administrative data. So in the first paper, excluding individuals from Quebec, and also in the second paper, we only included individuals from Ontario and Alberta, where we have full reporting of ED visits to the NACRS data set. We also only looked at incident outcome cases, so we excluded anyone with a previous alcohol attributable hospitalization or ED visit prior to the CCHS interview. And then one more exclusion of note is excluding those under 15 years of age. And starting at 15 years of age is common in alcohol harms research. And then we excluded anyone over the age of 65 at baseline only. And this is because this population tends to reduce their alcohol use, which could lead to biased measure of lifetime alcohol use if we use that exposure measurement at that point in time. So we follow people over 65, but it's just at baseline that we make that restriction. In terms of our outcome, we define them based on CI as indicator conditions entirely caused by alcohol. We did this to remain consistent with other alcohol harm literature in Canada. And this definition uses diagnostic codes listed as both the underlying and contributing cause of death, and includes causes such as medical harms due to alcohol, acute intoxication, harmful use, dependence, withdrawal, mental and behavioral disorders due to alcohol, and also alcohol liver disease. We use education as a measure of socioeconomic position, and we categorize them into group based on education achievement levels. We also, in a sensitivity analyses, used household income as an additional measure of socioeconomic position, although this variable wasn't harmonized across all CCHSs, so we prioritized education to have a higher sample size for our study. We characterized heavy episodic drinking using self-reported binge drinking, which was defined as consuming over 5 standard drinks on a single occasion, at least one monthly in the past year. And then we categorized volume alcohol use using the number of standard drinks consumed in the past 7 days to be consistent with the continuum of risk that was presented in Canada's guidance on alcohol and health. In the CCHS, sex is measured based on respondents' self-report to the question of whether or not they are male or female. Gender is not directly measured. We understand that male and female characterize biological constructs, although they likely capture both biological and social cultural aspects when asked in this way. As such, when we interpret our findings, we interpret them using the term sex/gender to incorporate both and to acknowledge both, and also women and men. This is important given notable sex differences in alcohol use or in alcohol harms, including differences in alcohol absorption, metabolism, and the distribution, which lead females to experience greater harm from the same level of alcohol, particularly over 6 standard drinks per week. We also understand that there are gender differences through socially constructed roles, attitude, and expectations, and that these entangle in relation to alcohol use and harm. And further acknowledge that these differences may be compounded at the intersection of sex and gender and also education. We adjusted our models for a number of potential covariates, including age, marital status, immigrant status, province, rurality, and survey cycle. And then in our analyses, we tested differential exposure by education, by looking at the sex and gender specific prevalence of heavy drinking and volume of alcohol use by education. We then estimated the association between education and alcohol attributable harm by incorporating for competing risks related to all-cause mortality. We also adjusted for the linkage survey weights to account for non-response and individuals who are not linked, decided not to be linked in the cohort, and then use 500 bootstrap replications to estimate the confidence intervals based on Statistics Canada's recommended procedures. To examine the differential vulnerability, we tested the joint effect by including interaction term between education and alcohol use. In order to do so, we further dichotomized education into low and high to improve the precision around the interaction effects. We formally tested the joint effects on the additive scale using the synergy index. And what this is it's the ratio to the joint relative effect of the 2 exposures when they happen together over the sum of the relative effect of each of the exposures independently. So because there's a ratio, what we see here is that when S is over 1, this indicates a superadditive interaction between the 2 exposures or a higher than expected risk. When it's under 1, it indicates a subadditive interaction between the 2 exposures or a lower risk than we might expect. So in our study, here we're looking at heavy episodic drinking by education, and we have men in the first grouping and women in the second grouping. Oh, I'll flip my slide for you. Oh. And so what we found here is we found no strong patterning by level of education. Actually, it's the highest 2 groups, the high school diploma and some post-secondary that had reported the highest levels of heavy drinking. We do note the strongly higher prevalence in men compared to women in our study. This figure similarly looks at the volume of alcohol use by education. And we don't see a strong pattern that would indicate that there's any higher volume of use in individuals with low education. So what we actually see is the prevalence of medium and high volume alcohol use, which increased with higher education, so higher rates and with higher education, up until the excess volume category, where men of bachelor's degree or above had a slightly lower prevalence, with no difference in women. When we look at the association between education and alcohol attributable harm, we see a strong patterning with low socioeconomic position or education. So here in the hospitalizations and death study, we see a roughly threefold increase in risk associated with less than secondary high school achievement compared to bachelor's degree or above. And we saw a very similar relationship when we looked at this in our second paper, with the outcome being ED visits 100% attributed to alcohol. In this figure, the results are included for the joint effect of education and heavy drinking. We included them for men and women separately, and heavy drinking status is then stratified by high and low education by their risk. What we see is that at each level of heavy drinking, that the individuals with low education experience greater alcohol attributable harm. And this occurs even in the absence of heavy drinking. So within that no heavy drinking category, if you look, there's higher risk in individuals with low compared to high education. We formally tested this again with having S ratios over, or synergy index over 1, denoting an additive interaction occurs, or a joint effect. When we look at this in relation to our second outcome of ED visits, we see very similar results. Again, with this higher risk in the low versus high education at a similar level of heavy drinking, and the additive interactions denoted in the synergy index. In this slide, we're looking at the joint effects between education and volume of alcohol use, and it can be interpreted very similarly. So here, if we concentrate on the excess volume category, we see the higher risk in low compared to high education. And then similarly across both studies, we find evidence of differential vulnerability, or a joint effect between these two factors. The relationship between women is consistent in direction. It's slightly less consistent in the ED visit paper, and we think this is due to low precision related to fewer women having alcohol attributable ED visits in our study. So overall, in a large longitudinal cohort studies, 2 of them, with over 15 years of follow-up in Canada, we found a strong association between low socioeconomic position and alcohol attributable harm. We found little evidence of a differential exposure to alcohol, either through heavy drinking or volume of alcohol use by education. And then we did find evidence, however, of this joint effect indicating differential vulnerability when we add together the effects of low education and both heavy drinking and volume of alcohol use. As such, our findings indicate that population level interventions are urgently needed to both reduce the high burden of alcohol overall, but also to consider socioeconomic inequities in alcohol harm. Our study findings should be interpreted with a number of limitations that are quite common in longitudinal studies looking at alcohol harms. So the first is potential non-response bias. And what this means is that individuals, this may be larger in individuals who report who are heavy drinkers, or who report heavy drinking or higher levels of alcohol use. There also might be a selection bias based on the CCHS sampling framework, where hard to reach populations are excluded, and these individuals may have higher levels of alcohol use. In addition, there's measurement error in the self-reported measures, and this likely underestimates the total alcohol use in the cohort. Compared to sales data, this is found to represent roughly 30 to 60% of the alcohol sales that we see in a given area. However, there is no evidence currently that shows that this is different by sociodemographic factors. So we think this is happening equally in low and high education groups. We also acknowledge that we only have alcohol use measures at one point in time, and this may not be reflective of lifetime alcohol use, and that the true socioeconomic inequities in alcohol harms are likely underestimated in our study, as they do not account for those partially attributable health harms like cancer or cardiovascular disease, and also non-health harms like violence due to alcohol. So there's three potential types of interventions or classes of interventions that we think we might consider based on our findings. So the first, as many people indicated, by intervening on the social determinants of alcohol use and harm directly. So addressing things like structural inequities, who then affect who accumulate over the life course to influence the risk of alcohol harm. And the added benefit of this approach is that it will, have a big impact on many different health outcomes and social outcomes. But we may need to spend some time thinking about how different alcohol policies differentially impact alcohol use in populations that experience inequities. So either through targeting groups individually, but even population level alcohol policies that impact all that apply equally to the full population may have benefits for reducing inequities. So as an example, in 2018, Scotland implemented a minimum alcohol unit price. So this affects the whole population. And what their evaluation uh, showed was that alcohol sales overall were reduced, but they were greater in lower income households. So there might be a differential effect in some of these policies that were, and this often requires specific studies to look at and quantify these effects. And the third one is just population level alcohol policies in general. So those policies that we know are effective for reducing population per capita alcohol use. So things like controlling alcohol availability, price, such as minimum unit price or taxation, and also advertising. So if they're reducing the overall alcohol use in the population as a factor that this disproportionately has risk for individuals with lower SES, we might expect to see differences in or benefits in terms of reducing inequities. So here I'm just bringing it back to hopefully bring all these concepts together to the conceptual framework from Whitehead et al. And so we can see the differential exposure and differential vulnerability hypotheses laid out here. And also, in addition, the different policy effects and how they come together to potentially influence inequities in alcohol harm. So with that, I'll finish my presentation and pass it off to Naomi, who's going to give us a specific example from the Ontario context, in particular related to sales in grocery stores.
All right, thank you, Brendan, for that. So yes, as Brendan mentioned, I'm going to talk about a recent pretty major policy change in Ontario and look at differences in social factors like gender. So if you are joining us from Ontario, you might have noticed the presence of alcohol starting to be sold in your local grocery store, which might have changed as early as 2015. So I'll just give a little bit more background on the expansion of alcohol into grocery stores. So this began in December 2015, where the government allowed grocery stores to be licensed to sell beer, cider, and in some cases wine. And the rollout occurred from 2015 to 2019. And during that time, slowly 450 grocery stores gained a license to sell beer and cider. So it wasn't all at once. And notably, still 450 grocery stores have a license to sell alcohol. This was the cap of the amount of grocery stores that would be permitted. So just to give a sense of the scope and scale of this expansion, a study by Dr. Daniel Myron's team found from 2015 to 2017, so only halfway through the rollout, that there was a 15% increase in alcohol outlets in Ontario, and grocery stores really were making up the overwhelming majority of these new alcohol outlets, about 90%. So the literature has been pretty consistent that an increase in alcohol availability is associated with increases in alcohol use and harm. And it's very possible as well, it's been found in the literature that grocery stores might have more impact, selling alcohol in grocery stores might have a greater impact on alcohol use, as it really increases the convenience of purchase when you can purchase alcohol at a grocery store. So for this reason, we wanted to study the impacts of a nearby grocery store gaining an alcohol license on adults' alcohol use in Ontario, and as well to examine the impact, whether these impacts differed by gender. So we hypothesized that alcohol use would increase consistent with the literature, and we also believed that this might be particularly the case among women. And the reason we believe that is because the past studies have shown greater associations with alcohol availability among women, even though this is just a small number of studies that have shown that. But women are also more likely responsible for household grocery shopping, and so they might have greater exposure to this new policy. So to answer this question, we used repeated cross-sectional data of Ontarians' adults' alcohol use. And so we got this from the Canadian Community Health Survey, or the CCHS, I might refer to it as. So it's a population-based survey that's conducted annually, and it's quite a large sample. About 30,000 Ontarians are interviewed every 2 years, or about 15,000 a year. There's certain exclusions in this sample, but for our study specifically, we used adults age 20 or over, not pregnant or breastfeeding, and completed the Canadian Community Health Survey from 2015 to 2019. And so we had to limit to after 2015 because of some changes then in the CCHS sampling method. And we limited to 2019 because of changes in alcohol use and availability that likely happened in 2020 due to the COVID-19 pandemic. So we have the list of stores that were licensed to sell alcohol was received from the Alcohol and Gaming Commission of Ontario, which licenses the stores. So the first step in the analysis was selecting the grocery stores in the areas that were exposed to these stores. So we looked at 308 Ontario grocery stores that were granted a license to sell alcohol from 2016 to 2018. So we limited to 2016 to 2018 so that we would have pre and post survey data available in our 2015 to 2019 sample. And we selected Canadian census dissemination areas. So those are small census units that can represent neighborhoods. So where the center of that population, of that unit weighted by population, was within buffer distances of either 1,000 meters or 1,500 meters of the 308 grocery stores. So just to show that quickly in a map across Ontario, you can see the location of those 308 stores across the province, and with a little more density in urban areas. I wanted to just zoom in to Toronto just to show the selection of those census dissemination areas highlighted in green, where the population weighted centroid fell within 1,000 meters of a grocery store. So the alcohol use outcomes that we measured were based on self-report in the Canadian Community Health Survey. We looked at the frequency or the amount of drinking, the frequency, and heavy episodic drinking. So for the amount of drinking, we used the measure of self-reported number of standard drinks in the past 7 days. For frequency, we used the whether participant reported on average in the past 12 months drinking 4 or more days per week, and heavy drinking was drinking 4 or more in women, 5 or more in men drinks on one occasion, at least once a month in the past 12 months. And these were all tested separately. So for our analysis, I mentioned how we selected our neighborhoods. So we selected the 2015 to 19 CCHS participants that lived within those selected neighborhoods. And those were our cases or our intervention group. We also needed controls so we could evaluate a controlled analysis that could control for the effect of other changes. So we selected from the Canadian Community Health Survey among participants that lived in neighborhoods that were at least 1,500 meters from a licensed grocery store, like any grocery store that any store that gained an alcohol license at any point during the study period. And we use something known as propensity score matching at a 2-to-1 ratio. So to select 2 controls for every 1 participant. And what propensity score matching allows is to select participants that are more similar to intervention participants. And we tried to ensure that these participants were similar along lines of age, sex, population center size, and CCHS cycle, as well as measures like race, income, and education. For our analysis, we used something known as difference in differences modeling, and we stratified by gender. So what differences in differences does, it allows us to look at changes over time in the intervention compared to the control group. So whether there was a greater change in the intervention group compared to the control group in their alcohol use. And so a value of 1 would mean there was no difference, and a value above 1 would mean that the intervention group had increasing alcohol use, an increase in their alcohol use compared to the control group. So we used negative binomial regression for the outcome of past 7-day drinking as its account, and logistic regression for the other outcomes of near daily drinking and heavy episodic drinking. So this schematic just here shows the selection of our population. So just to show how we define participants as pre and post. So for example, there were 69 grocery stores that were licensed in 2016. So if one lived in the neighborhood around those stores and completed the CCHS in 2015, they were assigned as pre. And if they completed the CCHS in 2017, 18, or 19, they would be assigned as post. And we pooled these participants across the CCHS cycles, and that yielded a sample of about 4,700 intervention participants and 9,400 controls as we matched at a 2-to-1 ratio. And when we used the 1,500 meter buffer, which was inclusive of the participants in the 1,000 meter group, we have a sample of about 10,000 intervention participants and 20,000 controls. So here's the first slide. I know it's quite busy. It has all our model results, but I mainly wanted to highlight what's shown in the red boxes. That shows a decrease over time, post versus pre, in all the alcohol use measures. So this was a bit unexpected, but we found from 2015 to 2019, there was a decrease in all alcohol use measures. And we know that this did not continue into 2020 following the pandemic. But it's important to know this because when you interpret the difference in differences estimate, it's important to know that a value above 1 means that there was less of a decrease in intervention participants relative to controls, as we saw decreases in both samples. So to show our the difference in differences terms for past 7-day drinking, we can see here that confidence intervals for all measures, both overall in men and women, and at the 1,000 meter and 1,500 meter buffer, they all crossed 1. So for women, we see some increase above 1 for past 7-day drinking. As well, we can see this association at 1,500 meters. However, confidence intervals crossed 1, so there is too much uncertainty in estimates to make any conclusions. Looking at near daily drinking, you can see that there's no clear or consistent pattern in the relationship, so likely no association. And when we looked at the outcome of heavy drinking, again, all confidence intervals crossed 1. We see some strong association for men at 1,000 meters, but again, confidence intervals crossed 1. And so there is no clear association found. So just to summarize those results, we found a pretty consistent decrease in alcohol use measures during the study period. However, there were no clear and consistent trends in the relationship between living near a grocery store, gaining an alcohol license, and increases in alcohol use, though some associations could be further studied. So just to discuss some of the interpretation of our findings, it's possible the rollout into grocery stores was quite controlled, though it was a pretty large expansion of alcohol use, of alcohol availability across the province. There were some limits on what products could be sold, such as, again, selling spirits or large package sizes, and where these products could be sold within the store. And overall, the LCBO released a report of sales and found only 3.9% of total LCBO sales in 2019 were from grocery stores. So might have had quite limited impacts. It's always difficult to measure exposure based on availability. While people might be more exposed to the closest grocery store, they also might not shop at the grocery store closest to their home. And so control participants might have been exposed and vice versa. It's also possible that increases could be concentrated in certain subgroups. So a past study in Finland that looked at alcohol in grocery stores found that those consuming the most at baseline had the most increase. So it is possible that those who consume a lot or have, for example, alcohol use disorder, when exposed to alcohol in grocery stores, will have more difficulty avoiding purchasing. So to discuss some limitations of this study, it's possible areas near a grocery store might be different in other ways from control areas. We know that they're generally more affluent and denser, the areas that received a grocery store with an alcohol license. We were limited to using repeat cross-sectional data for this analysis. It would be better if we could track the same participants using longitudinal data over time. However, this was what was available for tracking participants' alcohol use over time. We are also relying on the self-reported measures of alcohol use in the CCHS, and we're conducting this analysis at the time of other major changes in substance use policy, including cannabis legalization in 2018. So just quickly for some implications of our null findings, we believe more research is needed on the impacts of alcohol use among higher volume alcohol consumers or potential longer term effects of normalizing alcohol use over time. What are the impacts when we are selling alcohol amid food products on perceptions of alcohol that could translate to longer term trends in alcohol use. So Ontario recently announced that they plan to further deregulate alcohol sales by allowing sales in corner stores. And it's important, given the different scale and scope of this expansion, to continue monitoring the impact of these changes. So here's just quickly a citation to the study. And you can find it in the Journal of Studies in Alcohol and Drugs. And I will now open it up for questions.
So thank you, Dr. Smith and Dr. Schwartz, for sharing your important research. We will now move on to the Q&A segment of this event to address some of the questions from our audience. Please continue to enter your questions into the Q&A pod if you have not already had an opportunity to do so. So we do have a couple questions in the Q&A pod already. The first one, Naomi, is more of a technical question. So one of the audience members is asking, how is it determined whether or not a grocery store can sell wine in addition to beer and cider?
That is a good question. I'm not exactly clear on that. Grocery stores applied for selling alcohol and could, I guess, apply to sell wine as well. And the expansion of wine sales began in 2017. But I don't know which stores were allowed to sell wine.
Thank you.
Yeah.
And there is another question actually asked by a couple of our audience members, again for you, Naomi, about the statistical power. So what was the power of the grocery store study to show statistically significant results?
Okay, thank you for that question. So we did do a power analysis, and actually we tried to complete this analysis at 500 meters from a grocery store, and we're underpowered at that level. So we were able, with our study sample, to detect I forget the exact number, but I think it was about a 15% increase in alcohol use in number of standard drinks based on this study. And so that was we were powered to detect that at 1,000 meters.
Thank you. And Brendan, a question is being asked about your study. So someone is wondering why was Quebec and the territories, why were Quebec and the territories excluded from study number 1?
Yeah, that's a good question. So basically, it has to do with administrative data and the rights given by the province of Quebec to CIHI and the data linkage. So basically, we have people from CCHS from Quebec, but we had no follow-up in their administrative data, so it wasn't available, and that's quite common with Quebec administrative health data. For the territories, it was actually the question, some of the alcohol use questions, so the exposure measurement, are voluntary and they weren't asked in the territories. So again, it just has to do with missing data. It wasn't intentional exclusion. We actually were trying to make it as Canadian representative as possible.
Thank you. Another question, this is more of a general question from one of our audience members. Is there an estimate of the health effect of deregulation of alcohol in Ontario? And if not, how can we calculate it? So I don't know if one or both of you want to take a crack at that.
Yeah, it's a good question. So we were attempting to measure it a bit in terms of the expansion. I think deregulation could take different forms, whether it's an expansion of availability or allowing different stores to sell alcohol. In this case, it was a bit of a controlled deregulation into grocery stores, and there might be a different impact depending on corner stores. I don't know of an exact measure here, but it would likely involve tracking changes in availability, looking at which populations would be most exposed, as well as impacts on things like prices, which could then be monitored. But I don't know if Brendan, you have anything else to add?
I think the study is a really nice example of that, right? So it uses a natural experiment that happens, and so it has a more quasi-experimental design, and this means a lot actually when you're trying to determine like the causal effect of a policy. So I think actually studies like the study that was presented can be really helpful in trying to estimate those effects. I don't think there's any one single effect. The effect might be different depending on where it's sold. So corner stores versus grocery stores, these are in different locations geographically or tend to cluster in different neighborhoods related to socio-demographic factors. So all that to just say, like, it's really complicated, but I think that studies like this are a big step forward to improving the evidence base.
Thank you to you both. Brendan, could there be bias in how outcomes are recorded in admin data? So for example, people with lower education are more likely to have a diagnosis related to alcohol regardless of their actual use.
Yeah, yes, definitely. It's hard to get into the nuances of the different interactions and how those might be interpreted along certain biases. But there's a quite a strong literature of biased access to healthcare or outcomes being inferred related to racism or other factors that may definitely play a role. So yes, admin data is not immune to that type of bias.
Thank you. Naomi, one of the audience members, says, interesting study. How sensitive do you think your results are regarding the distance buffer around the grocery stores with alcohol?
Okay, thank you for that question. So we did want to look at that and looked at the size of the dissemination areas as to whether we could measure access based on access from a dissemination area. So in some cases, particularly in rural areas, these dissemination area neighborhoods get very large, and that would make it less accurate for testing this. However, the majority of these neighborhoods are quite small, under 1,000 meters. So we think it is a pretty good approximation of somebody who lives in that dissemination area's exposure to a grocery store.
Thank you. And maybe just a follow-up question. So you had mentioned it may be different during and following the pandemic in terms of access to alcohol use. Are there follow-up studies being done now post-pandemic to determine if the decrease in alcohol use persists or what this might look like?
I personally have not seen that. I know there has been a lot during the pandemic to show that there was an increase based on the stressors of the pandemic. However, I have not seen how that trend has continued since COVID measures were relaxed.
Thank you. Another question from our audience. Do you think the SES gradient in alcohol harms would be even more pronounced if harms that are partially attributable to alcohol were included in your study, Brendan?
Yeah, that's a good question. I'm not actually sure the direction it would be. Immediately, I was thinking like, yes, they would be more pronounced in terms of like that there's so many of these other factors at play, other mechanisms that contribute to not just alcohol, so for example, for the reason for getting cancer. So we do see social inequities in a lot of the different partially attributable alcohol harms. But yeah, it'd be an interesting study. It's actually something we're working on a bit. So it's really hard to estimate or attribute those partially attributable health outcomes to alcohol, things like cancer, like to an individual and therefore to a socioeconomic position. So it's very hard to actually estimate those factors, but it is something that we're working on in the lab to try and improve the methodology around it.
Thank you. Naomi, you had mentioned Dr. Daniel Miron's work in your presentation, and one of the audience members is asking, how would you put your findings in context of Dr. Miron's findings on alcohol access and ED visits in Ontario?
Yeah, thanks. So I can just explain that Dr. Daniel Miron conducted a study, I believe looking to 2017, that looked at impacts in neighborhoods that added a grocery store on increase and showed that there were increases in ED visits in those neighborhoods. So Dr. Daniel Miron was on this study. So we wanted to look at this association in different ways, whether it increased ED visits and alcohol use, because it's important to confirm findings and see if we find similar findings in using a different outcome measure. It's possible we did not find an effect. I mentioned that it's possible effects are restricted to certain parts of the population, like those who have high alcohol use at baseline, which we couldn't detect in a population-wide sample. And so if that is the case, those who are using more alcohol will begin using more. It's possible that ED visits could increase, even if alcohol use across the population doesn't. However, it's also possible that using cross-sectional data like we did, it's just difficult to be very sensitive to detecting small increases in alcohol use.
Thank you. Are there plans to continue the studies with the changes in Ontario coming or being announced, I guess, in December?
Right. We would certainly like to study those changes. I think it would be very important, considering the different context of increase that might occur, for example, when corner stores, if corner stores begin selling alcohol, for example, a very different socioeconomic context with alcohol in grocery stores, as I mentioned, being more located in wealthier neighborhoods. So yes, I think this would be important to continue studying.
Thanks, Naomi. And just keeping an eye on the time, I have one last question. And Brendan, this is for you. Someone from the audience commented that they found it interesting that increasing minimum unit pricing for alcohol decreased purchases to a greater extent among lower SES households. Although that is intuitive, they remember a similar study on tobacco from England that showed the opposite effect. So if you could maybe talk a little bit about why you believe there was a stronger effect of the minimum unit policy among lower SES households.
Yeah, for sure. So I can't speak to the idea around tobacco. I think as it relates to minimum unit price, like a lot of the products are really high around that minimum price that get bumped up, or like high volume cheap alcohol. So it's not like everything will increase, but just you're talking about that lower band in terms of what it might be. We know from a whole host of literature that, of course, individuals with lower socioeconomic position will be more sensitive to price change related to the material resource or percent that of their income that it would take to purchase these products in terms of having economic power. I will say that although like there's the large debate about whether this is equitable in order to have these pricing type interventions, so things like sugar sweetened beverage tax or even around alcohol. And I think one of the ways that we can do that is ensuring that a percentage of the tax revenue related to those changes results in improving the social determinants of health. And I think that's a really interesting approach that's been proposed by ethicists and others related to this. So yeah, I think that might be why specifically for alcohol. I'm not sure if it holds for tobacco.
Well, fabulous. Thank you so much, Dr. Smith and Dr. Schwartz, for sharing your research today. We're going to wrap up our PHO rounds. I would like to thank everyone who joined us for today's webinar. You can expect to receive a brief and anonymous PHO round survey for today's session. Please try to complete this to help us improve our programming. A reminder to everyone that topic, the Ontario Public Health Convention, will be held on March 26th and April 3rd of this year. Please check out topic.ca for details. And lastly, to access past PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you and have a wonderful day.